Welcome to this Clinical Explainer. Today, we're acting as our expert consultants, deconstructing some of the highest yield diagnostic matrices you'll face. Let's jump right in.
Here is our roadmap: cardiorenal, obstetric and endocrine, toxicology, and urinalysis.
Module 1, Cardiorenal Matrices. Picture a systemic sclerosis patient suddenly presenting with malignant hypertension, 220/120, respiratory distress, and a rising creatinine. Classic flash pulmonary edema. Now, standard pulmonary edema screams for loop diuretics, right? But in scleroderma renal crisis, massive RAS activation completely drives the pathology. Your absolute mandate, a short-acting ACE inhibitor like captopril, explicitly overriding standard rules against ACE inhibitors in acute renal failure. Beta blockers or diuretics will completely fail here. Next, we have a healthy 53-year-old crashing into cardiogenic shock with a new left bundle branch block. Her only trigger, naproxen for bruised ribs. Why? NSAIDs block COX-2, completely wrecking endothelial prostaglandin balance and spiking her acute MI risk. Seemingly benign over-the-counter NSAIDs carry massive hemodynamic weight. Module 2, Obstetric and Endocrine Intersections. Consider a pregnant patient at 20 weeks with tachycardia, weight loss, and a suppressed TSH. Over hyperthyroidism. She needs meds, but timing is literally everything. The strict rule here: PTU is for the first trimester only. At 20 weeks, you must switch to methimazole. Using methimazole in the first trimester risks fetal aplasia cutis. You have to respect that timeline. If she crashes into a thyroid storm, beta blockers are your cornerstone. But wait, what if this was actually some pathomimetic toxicity from cocaine? Beta blockers are absolutely contraindicated there. They'll trigger a fatal hypertensive crisis. Seeing hyperthermia with lower extremity clonus instead, that's serotonin syndrome, mandating cyproheptadine. You've got to nail the exact trigger. Now, any pregnant patient with pre-existing hypertension must be monitored closely for preeclampsia, which is fundamentally driven by abnormal placental spiral arteries and poor trophoblastic invasion. Untreated, this devolves into HELP syndrome. But if you also see profound hypoglycemia, a prolonged PT or PTT, and high ammonia, you've crossed the boundary into acute fatty liver of pregnancy. Both feature third trimester elevated transaminases and low platelets, but missing AFLP synthetic liver dysfunction is a fatal mistake. Module 3, Toxicology and Mimics. A 27-year-old with a peanut allergy uses her EpiPen immediately, but still arrives dangerously hypotensive at 85/42. Why is she crashing? Epinephrine constricts arterioles, sure, but anaphylaxis is an IgE-mediated distributive shock. The vascular bed is wide open. You must slam in isotonic saline to restore preload. Epi alone can't pump a dry tank. Contrast that rapid shock with a kid developing hives and severe joint pain 10 whole days after getting a botulism antitoxin injection. That delayed timeline is classic serum sickness. It's a type 3 hypersensitivity where circulating antigen-antibody complexes take days to form before depositing into tissues, triggering massive inflammation. And here's a non-negotiable rule. Suspect a pheochromocytoma, you absolutely must block alpha receptors with phenoxybenzamine before touching a beta receptor. Unopposed alpha-1 vasoconstriction will cause a catastrophic hypertensive crisis. Alpha always precedes beta. Finally, Module 4, the renal matrix. A positive dipstick for blood is a trap. It's just detecting heme. Check the microscopy. Myoglobin from rhabdo or meds like rifampin cause false positives. Zero actual RBCs means you're dealing with pigment, not a bleed. What about sterile pyuria? White blood cells but zero bacteria. If you see this alongside urinary eosinophils, it points definitively to acute interstitial nephritis, a kidney hypersensitivity, often triggered by NSAIDs or PPIs. Conversely, if an older smoker presents with painless, gross hematuria and intact RBCs, bypass the medical management. That demands immediate cystoscopy to rule out bladder cancer. Let's synthesize this. An Rh-negative pregnant trauma patient presents with vaginal bleeding. Do you just give him Pyrrhic Ramogam? No way. The strict alloimmunization rule mandates an indirect Coombs test first to definitively confirm her sensitization status. In reality, these pathologies always intersect. Trust the matrices and you'll nail the diagnosis. Thanks for joining this explainer. Catch you next time.